We're going to get started. So good afternoon everyone and welcome to this webinar on managing the return to work of a COVID-19 patient. I'm Andy Thomas, Director at PhysicWhip, and the landscape, as we all know, has drastically changed over the last 6 months. So the NHS and other employers are having to adjust the way they work, and today I'm really looking forward to this session because we're going to hear how an NHS team have developed and delivered a rehab pathway for COVID patients aiming to return to work. So once we've had this presentation, we would love to address any questions that you've got, which hopefully will be stimulated from the presentation. So please put these in the questions tab below. Mary will be monitoring that. She's joining me today. So anything like that, we really welcome any question at all. So our presenter today is Sarah Holt. Sarah is a clinical specialist occupational therapist who qualified in 1997 and has spent the whole of her career working in Derby, and for the past 20 years has worked in musculoskeletal outpatients. Sarah now manages the team of MSK OTs and physios and specialises in vocational rehabilitation. From my perspective, I'd say Sarah's a real pioneer within our customer base, as she's developed a great working relationship with local industry and created a significant income generation stream for her department, which from the NHS is a really great achievement. So hopefully that's a good intro to you, Sarah, and I will now pass over to you.
Okay, hello everybody. As Andy said, I'm Sarah, an occupational therapist in Derby. We developed a COVID rehab pathway fairly rapidly. We felt that it was necessary for this to be done as quickly as possible. We had some discussions with inpatient teams, consultants and management within the trust, but essentially we already run an occupational therapy vocational rehab service, so we felt that we could adapt it fairly quickly to respond to the growing need of COVID rehab patients. Our target audience is people who have had COVID, who are aiming to go back to work. They should have some ongoing physical deficit that's affecting their ability to do their job or to perform quite specific work tasks. I'm sure that some of you will know, and hopefully some of you are already doing them. We've been able to, since the beginning of this year, write fit notes for people. So allied health professionals are now able to write fit notes, as I hope you know, and this has been a real asset to the service. We found that GPs are very busy trying to limit their face-to-face contacts. We also found that their ability to return to work has been so incredibly variable that's allowed us to design the fit notes and advise employers as specifically as we need to. So we have 2 referral pathways. These again are fairly, they are already in existence. So we have a staff service here. We accept referrals from staff service physiotherapy, from occupational health, and we also allow staff members to self-refer with their manager's signed consent. This has been quite a big offering for us with COVID patients, which we'll come on to in a little while, and is the subject of the case study that I'm going to do at the end of the presentation. We also have NHS referrals. So these are referrals that we accept from inpatient therapy teams, from consultants, from respiratory nurses, community therapy teams and GPs, and they have come in from every one of those sources. So it's been a growing thing. We've built relationships with teams that we've not used to having contact with at all. Hopefully this is similar for other people, but we've developed forums, not only between therapy, but between all interested parties in the treatment of COVID patients. So respiratory consultants, ITU staff, community staff. So the common problems that we have come across, and I would say even since I've written this list, it's a never-changing list. Things crop up that perhaps haven't done before. I've just seen somebody today who actually is a physio himself, who's experiencing quite a lot of problems with headaches. That's not necessarily something that we've come across all the way through, but that's, other than fatigue, is his biggest issue. So we have come across weakness. This is fairly broad, nothing too specific. Breathlessness is an issue, as we would expect it to be. Fatigue is probably the single biggest issue with the patients that we're treating that need to go back to work. There's quite high levels of anxiety. Rapid heart rate, that's something that's cropped up quite a bit over the last few weeks. Joint pain, again, nothing too specific. This back pain thing's a fairly new thing for us, but generalised joint pain, small joints, large joints, you know, generally linked, I think, to lack of activity and when their fatigue levels are high, which obviously we would expect. Lower rib pain, actually that cropped up quite a lot at the beginning. That seems to be less common currently, but that may be just the patients that we've got at the moment. So our observations, so again, ever-changing observations. We had a huge amount of talk at the beginning about neuropathy, cognitive issues, getting neurological services and neurological therapy involved in these patients' care. Hasn't been quite as prevalent here in Derby as we imagined it would be. I'd be interested to know if that's the case for other people, but certainly it's not something that's cropped up particularly here. Sometimes, occasionally, a little bit of brain fog, fatigue related cognitive issues, but nothing particularly significant. But I suppose it's important to point out that, of course, we're only seeing people of normal working age generally. So whether that's a little bit more prevalent in the elderly, I couldn't possibly say, because that's not something that we're actually doing at the moment. One of the biggest things as well that we've noticed is that we're having more ongoing issues with patients who haven't had the prolonged hospital admission and they haven't been in intensive care. The intensive care patients are progressing in a way that we would expect them to progress, and as a general rule are following a nice, can't say the word trajectory, in the way that we would expect them to. The patients who haven't had that prolonged admission are actually struggling more. Their recovery fluctuates an awful lot more. Some of the patients that we're treating had their initial onset of illness 6 months ago, and we're still not in a position to allow them to go back to work or to encourage them to go back to work. So again, it'd be quite interesting to know if that's been the experience of other people. A lot of our patients in that situation are actually staff. So the healthcare professionals who've contracted COVID and, you know, are really struggling to get back to their normal employment. Again, it's something that we've noticed, and actually there's some interesting evidence coming out around the link with estrogen in how severely unwell someone is, but also how they recover. There's a lot more information about inpatient stay and people who've been on intensive care and the severity of their illness in the first instance, less so on recovery, but obviously recovery is still happening. A lot of our patients are staff, as I say, they're females in their late 40s, early 50s. So whether there's a menopausal thing associated with this, I don't know. But we do have patients who are currently working with their GPs to just try and get on top of potentially menopausal symptoms to see if that has any impact on their COVID recovery or not. A lot of the staff referrals are for people who were redeployed onto COVID wards. So as you can imagine, what comes with that is a degree of anger that they were put into that situation. And I think if they felt that they were being fully supported by their employer, then maybe that anger wouldn't be quite so significant. I think the difficulty is it's such an unknown quantity that I think most managers don't know how to deal with it. If it doesn't follow a normal pattern of recovery, then it's very difficult to plan a phased return, as I'm sure everybody can imagine is probably experiencing themselves. So as I say, the symptoms are inconsistent, and that obviously impacts on their functional ability. How much of this is linked to fatigue and energy levels and having a knock-on effect on the other symptoms, obviously we can't say for sure, but certainly when their levels of fatigue are high, joint pain's more prevalent, anxiety increases. When anxiety increases, breathlessness tends to increase. So all these things are having a knock-on effect on each other. And as our primary concern in the department is musculoskeletal conditions, and of course this is quite a big learning curve for us as well, as it is for everybody. I think, having discussed quite recently with one of the respiratory consultants, his feeling was that those that have been unwell and to the point that they've been in intensive care, their recovery is following a similar pattern to normal pneumonia. That was his feeling. It wasn't particularly different. So whether that will change or whether new things will come to light, I don't know. So the case study. So the patient is a healthcare assistant. She normally works in an outpatient clinic in a community hospital. So she was redeployed onto a COVID ward on the acute site. So quite a significant change for this lady, coming onto the large acute site, into an area that she wasn't familiar with, duties that she wasn't familiar with, and then fairly early on in the pandemic contracting COVID-19. So she was diagnosed in early April. So for us in the UK, that was fairly early in the grand scheme of this situation. She did go to A&E, but she didn't go beyond that. So she recovered at home. So she didn't have a full admission. She's 52 years old and she lives alone. So fairly typical of those patients that I described a couple of slides ago. So her presentation, she was referred via staff service physio, so not by a healthcare professional that was treating her. Like I say, we can self-refer here, so I think that it was very much of her, she instigated this completely because she really was struggling to move on from that acute stage. So at that point, she was 2 months on from her onset of illness. So we started treating COVID patients in May, so fairly quickly from the onset, and certainly from people being in a position where they could even consider rehabilitation. So she was 2 months on from onset when she came to us. She had ongoing issues with breathlessness. She had limited walking tolerance and often talked about an inability to walk and talk at the same time. And for a long while we assumed that that was linked to the breathlessness, and it was actually, as she exerted herself a little bit more, it made it more difficult for her to talk. But there also does seem to be a difficulty in her doing too many things at the same time. So even to the point of being able to multitask by walking and talking. As a HCA, obviously that's quite a big part of her job. She's not going to be able to stand still every time she needs to talk to a patient or a member of staff. So quite a big factor in her return to work, and still an ongoing issue for her. She had very high levels of fatigue with very much that boom and bust pattern that we would expect. She had high levels of anxiety, of anger and of guilt, and very much in the way that I just talked about. So she was very angry about the fact that she felt like her employers had forced her into a situation that had made her unwell and essentially changed her life, whether it's in the short term or the long term. She was also quite angry that she didn't feel that she was fully understood and supported. Presumably colleagues listening will probably appreciate that there's an awful lot of people working in healthcare who've contracted COVID, and some people have gone back to work sooner than others because some people have been affected less than others. So of course that anger about her being more affected than other people, but also guilt in the fact that she felt a degree of pressure to go back to work. Her feeling was that pressure was also coming from management. Having been in contact with them on numerous occasions, I think that was fairly internalized. It was internalized guilt rather than anybody inflicting that upon her. And just generally anxiety about her situation, anxiety about work, anxiety about the future, and probably exacerbated by the fact that this lady lives alone and didn't really have that outlet to talk. We found that the initial contact with these patients can feel like counselling, and it's been quite challenging for them to appreciate the need to have CBT or some sort of counselling as part of their rehabilitation, because in their minds they have a physical illness, and don't necessarily accept that anxiety could do to be treated in a different way. She did have some weakness. This was primarily upper limb weakness. She talked about the fact that she couldn't open bottles and jars at home. She found anything where her, particularly working with her arms in elevation, was quite challenging. So washing and drying her hair, cleaning anything at a higher level. She also found hoovering quite challenging, partly to her upper limb weakness, but also I think that hoovering, she exerted herself quite a lot, and she felt that made her breathlessness significantly worse. So as I'm sure everybody else is doing at the moment, our initial consultation is on the telephone. We do have attend anywhere, so virtual consultations if needs be. We're trying to gradually increase our face-to-face contacts. So we haven't ever stopped doing face-to-face contacts, which I know some people have. We didn't stop that, but we minimised that as much as we possibly could. So this initial consultation on telephone was about an hour and 20 minutes, to be fair. So I think because a lot of these people haven't been supported, the people who've been in intensive care, I think one of the reasons, or even if they've had a prolonged admission that didn't involve intensive care, is one of the reasons they've recovered better is they have such a lot of information given to them. They have access to an awful lot of healthcare professionals. There's quite a structured follow-up, presumably nationally, certainly in our trust there's quite a structured follow-up. So these people that recovered at home, unless they actually choose to make an appointment with a GP, they're struggling to get any sort of input at all. So there's no follow-up for these patients in a hospital setting unless the GP identifies that further help is needed, really. So we talked about what the ongoing functional issues were. Obviously the main reason they're referred to us is to go back to work, but of course we don't disregard the other issues that there are in their life. So how she's managing currently at home. We talked about her work role, you know, trying to go through the potential difficulties, the most physical elements of the job, what were they? And then initially trying to give us some home exercise, because again, if they're recovering at home, the chances are they've been given no advice about any sort of exercise at all. So we've been sending a lot of the stuff that they have been given to inpatients, we've been sending out to outpatient, to people that haven't had that inpatient stay as well. You know, it's taken some time to develop packages of information, but they're there now. And actually the NHS have got quite a decent website now that people can go to if they need to. That wasn't really there at the beginning. So we now do everything electronically, as I'm sure everybody else does as well. So sending out exercises, you know, most electronic systems for exercise provision are physio related, and certainly the ones that we can access here. So it's trying to make sure that that had that OT element to it, that functional element to it, and it's starting to consider things that might ultimately help her to get back to work. And we gave her a AHP Fit Note, which again we can do electronically. For those that haven't seen it or know anything about it, they are a lot more detailed than a GP referral, so there is a necessity to identify specific problems and recommend what the solutions might be and what are we going to do about this to enable this person to go back to work. So, you know, I think so far this lady's had about 5 from us, so you know she has had quite a lot of fit notes. So we gave her quite a lot of information, like I say, verbal and written information on fatigue management and any COVID specific information that we had at hand at the time. So obviously, like I say, that has developed. So as time's gone on, we've been able to give people more and more information as it becomes available to us, really, and also from experience and picking up patterns and things like that. So we've had discussions with respiratory services regarding the breathlessness. So I don't know what other people have experienced, but we do have respiratory specific rehab services, respiratory physio, outpatient services here. There's a wellbeing program that's run by an OT. Most of these patients don't meet the criteria for that. So they, you know, we tried using hyperventilation scales and things like that to try and prove that they were candidates for this service, but generally they're not. Fortunately, because we built relationships with some of these services, they were kind enough to come up and do a session to a few of our COVID patients at the same time, so they were happy to just drop in and give them some information about how to do breathing exercises, how to control their breathing, how to be aware of triggers and things like that. And we also at that point advised her to self-refer to psychological services and start that process off. Again, very reluctant to do so, but agreed to it in the end. And I think that's just coming to an end now. I think she's just finished that course and is very, very glad that she did it in the end, much as she was so reluctant in the beginning. So her main concerns, and the main concerns for nearly all of the patients, is working hours. Most HCAs will do 12.5-hour shifts. As this particular patient works in outpatients, fortunately she only does 8.5, I think. But for some of the patients that we've had, it's quite lengthy shifts. And as a general rule, as I'm sure most people know, if they go to occupational health within the NHS, if they go to HR, there's quite a generic way of doing a phased return, and that almost requires them to increase their hours on a weekly basis. This is just not feasible for these sorts of patients. They can't do that rapid increase. We had patients that by the time they'd referred to us, they'd already had a failed return to work because they'd just tried to increase it too rapidly and it had failed. So working hours has been the biggest theme throughout. For this lady, of course, there's also manual handling tasks. pushing wheelchairs in the outpatient setting, moving equipment, assisting with sit-to-stand transfers and positioning patients on a bed, plinth, whichever you would like to call it, couch. So rolling patients towards them, rolling them away, things like that. The communication and social interaction was quite a big part of it. You know, the high levels of anxiety and the psychological difficulties that have come from it make their social interaction quite difficult. Also the fact of this inability to walk and talk at the same time. When they become more fatigued, they find that they start to suffer a little bit with word finding difficulties just through sheer fatigue. And then the prolonged upper limb activity. So there's a scanning machine that this lady had to operate that had a winding motion, and she was struggling with any prolonged upper limb activity. So the lady had a childhood condition that we've never really got to the bottom of what it is. She couldn't remember. So there was some concern that maybe there was a predisposition for this, and but we've never really got to the bottom of that. So we assumed that it's COVID related. So our environment is a gym, essentially, in many ways. We do have rehab specific equipment. So we decided that it would be sensible. I think initially there was a big push from our managers to have a COVID specific group from an infection control perspective. I think for us, we really felt that it was important they were with other people to have shared experiences, and because they felt very alone, it was very important that they had the opportunity to meet other people. And I think that's been a big part of it, the talking with other people, talking with ourselves has been a big part of it. There have been sessions where they've done very little in the way of exercise because they've spent so much of it actually just talking to each other, and we actively encouraged that. Less so now, we're trying to get them moving now, but at the beginning we felt like we wanted to give them the opportunity to have a shared support mechanism. So there is an element of cardiovascular exercise. Obviously that has to be done in short spurts because we need to manage the fatigue. There is obviously with this lady particularly upper limb strengthening. That was quite a big factor for return to work, but something she'd also identified at home as being difficult for her. Work simulated activity, of course, is always part of vocational rehab. You know, as much as possible, it's about trying to simulate the actual task, not just the component parts of it. We did this session, like I say, with the respiratory specialist physios who came up and kindly talked to the patients for us. We have looked at using hyperventilation scales and fatigue scales to inform rehab and potential onward referral, but also because they've used some of these scales if people have had an admission, that we can then see what progression they're making. And then I say huge psychological support from staff and other patients as well. So when it comes to the Primus, I mean, in an ideal world, and what I suggested we were going to do, which hasn't quite happened, is we were going to try and look at doing the same evaluations for every patient. I think because their abilities fluctuated, their moods fluctuated, their attendance has therefore fluctuated. It hasn't quite panned out in the way that we may have liked it to. So partly with this lady because she was struggling with grip and opening things and closing, you know, opening jars, bottles and things like that at home, we wanted to make sure that we did a grip evaluation. I did actually print off the graph, so I'll skip ahead. So we've actually done the evaluation 3 times, and I think I just wanted to draw attention to the first time that we did it, because the fluctuation between the first evaluation, the first grip, and the third one was significant. So that ability, the initial strength seemed to be there, and then it significantly dropped off by the third time. But then on the third occasion, you can see that that's the bit that's changed the most. So actually, there's still a degree of fluctuation. This lady on the 4th of September, when she did the graphs at the bottom, actually, if you look at it, her grip was a little lower, but it was much more consistent. So she wasn't having a great week that week, so she'd had a bit of a flare up in her fatigue, but I wanted to actually still assess a grip in that situation to see what impact that would have. So I think what it represents there, even if you've never done this sort of evaluation before and haven't seen these graphs, is how much this condition fluctuates. It doesn't necessarily follow a pattern. You know, in the top right hand corner where it says progress, I mean, you can see the green line, it jumps up between the first assessment and the second assessment and then drops back down. And then but actually say overall the pattern is more as you would expect it to be, so not a significant difference between the first squeeze on the dynamometer and then the third one. So unusual, I would say. And then we wanted to sort of simulate sustaining a pull towards us, so a roll towards a patient and a roll away. So with that, again, for some of you will be familiar, but we used this attachment for an isometric evaluation, so actually sustaining that pressure, 3 repetitions, 10 seconds for each one, to sort of get it close to something that might replicate the process at work. And with that particular one, I haven't printed off the results of that, but I actually think she did better than she anticipated she was going to. So we've done things using a weights machine, and she found that pulling towards her far easier than pushing away from her, and that seemed to give her a lot of chest tightness. So whether that was a muscular issue or whether that was breathlessness and you know, I don't know what was going on there. So I think she surprised herself how well she did. And then we also wanted to do, every time she came in, a program of rehab, really. So, you know, what would we do? So using repetition to build tolerance to some of these activities. So grip, I don't think I've got a picture of that one. Opening a jar, that was something that she particularly, obviously she went, that is not her doing it, that's actually me trying to stay off camera. So I'm at a stretch, so I'm not on camera, but just so that people who perhaps aren't familiar with the machine can see the attachments that you can use in this situation. So actually getting her to practice trying to turn. She lives on her own, she's fiercely independent, and it was driving her crazy that she had to ask people for help with things like this. And then this attachment was used to try and get close to the movement that was required and the position that was required for this scanning machine that's operated on a joystick. So she's been using that to try and do sustained movement that's required for this particular process at work. Yeah, so pushing and pulling, rolling the patient, opening a bottle, opening a jar, gripping repetitively to try and build up the grip strength. We did some stuff with that way, sorry. I didn't put that one on. So using 181 to go into a higher position as well, sorry. So using this attachment in a higher position to practice reach, because obviously doing any activity above shoulder height, was causing us some difficulty. So actually doing it in an elevated position to improve that as well. Yeah. So, and as well as that, so things that we would do otherwise, you know, say using typical gym equipment really, but treadmill work, some balance work. There's a bit to talk about balance and vestibular issues that potentially are associated. Not a significant problem for this lady, but something that we would actually consider while she's here. You know, so exercise bikes, treadmills, weights machines, and then a big amount of time using the Primus, but also talking, a huge amount of time talking. So you know, we give them an hour session. They don't feel that hour of exercise, so it's much more a long 30 minutes of exercise broken up with various times to talk and chat and to try and figure things out. So yeah. And then I think, do you want me to leave that one on, Andy? Sorry. Have I put that in the wrong order?
No, you can leave that one on, that's fine. That's fine. We'll actually go on to the next one because then we'll be for the questions. So yeah, so that's great. So I've got a couple of questions before we go on to the ones that are coming through as we speak. So with that particular patient then, so you're saying it was an hour session that you had with them? Mm-hmm. And then, so how much would you say was from an assessment perspective, and how often would you see them?
So we're doing it once a week. They've got an awful lot of homework to do because obviously, you know, most of them are at home exercising, walking, trying to build activity and get back to normal things really. So we're restricting it to once a week, but partly that's capacity for us as well. So just to give you a little bit of background, we normally treat about 70 patients a day. We're limited to a maximum of 24 over the whole day now. So we're We used to have groups of up to 15, 20 at a time. We're restricted to 6 at a time at the moment. So some of them may well benefit from more than once a week. I suspect they probably would, but in order to be fair to our normal caseload of MSK patients, we need to be able to offer the opportunity to as many people as possible. So that's part of the reason. And then, yeah, so it's always a constant assessment. It's not as formal as saying that's when you're going to come and you're going to do exercise, and then this session you're going to come, we're just going to sit down and assess you. If we go and do a session on the Primus, we'll do you know, some of the rehab stuff that we would normally do. We may do an evaluation. I mean, with her, we've been evaluating it probably once every 3 weeks or so, depending on attendance and depending on how she's feeling. So, yeah, I don't know if I can answer how it's equally shared. It's a constant assessment process, I would say. And at the moment, I think because they're a little bit inconsistent in their ability and therefore their attendance, and we've had some really warm weather, abnormally warm weather, and they haven't coped very well with that. So we're only looking at probably having around about 3 or 4 patients in at any one time, and there'll be at least a couple of therapists and a couple of assistants in the vicinity. So we're able to assess them quite constantly, I would say. And certainly when they're due to have an extension to their fit note, or we're looking at whether they're in a position to go back to work, then we would be certainly evaluating that more closely at that point, and then using the information that we get from the Primus to inform that fit note. You know, it gives us a lot more objective information to put on that fit note. It's been quite useful because I say that they're more extensive than a GP's one, but actually it's still limited word count on them, especially when you're filling them in electronically.
I think that's a good time now. So one question we've had come through is, can you explain a bit more about what's a fit note? What does that involve?
So up until the end of 2019, the only people in this country that could write a sick note or fit note for a patient to either go back to work, stay off work, or do a phase return to work was a GP or a consultant, so essentially a qualified doctor. For a few years now, we've been able to do allied health professionals advisory notes, which means that we can write something very similar to the format that we can. I should have put one up for you actually, to what we do now. But it was never considered in isolation. It couldn't be the only fit note that they had. They'd have to have a doctor's one and then a therapy one to go with it. So at the moment, I think the only professional organisations who signed up to it are occupational therapy, physiotherapy and podiatry. There was talk about extending that to more people, but as it stands currently, I think it's just those 3 professions. There hasn't been a big advertisement to say go ahead and do them. It wasn't an announcement to say right, you can go ahead and do them, but actually we've had that ability to do them since the beginning of this year, and it just allowed. So I wonder if I got one. Have I got a blank one anywhere? Let's see if I can put it up to camera for you. So it has 4 sections. You can write 4 main difficulties on one side of the page, and then on the other side of the page you can write why it's a difficulty related to work, and what you can do about it essentially. So when GPs write them or consultants write them, they would literally write diagnosis, and then maybe there's quite a big box for narrative, and it generally isn't filled in. But you can say whether they are. So you can tick to say that they're not fit for work, or you can tick that they might be fit for work if the following recommendations are considered, and then you can say whether they do reduced hours, reduced duties, whether you would recommend a workplace assessment. So for us that's great because we do a lot of workplace assessments in normal circumstances, so it's nice that that's being recognised as a really good tool for getting people back to work.
Okay.
But we're going to try and print one, and I'll put it up to camera if people haven't seen one.
And then one last question that I just had before we go on to some of the other external ones. So the fluctuation that you saw with this particular patient, how did they respond to that? Better now. At the beginning, not great. I think that the fluctuation in fatigue would then have a big impact on the psychological well-being. But I think now, hopefully, with our support, then she's learned to not react so strongly to those
and to expect them almost, but to be responsive to them. And it's always about that boom and bust, and it's the same with anybody who needs to pace with, no matter what's wrong with them, really, isn't it? That, you know, when you're feeling a bit better, or then that's the danger point, because people then push themselves to do a bit more than perhaps they should, and especially when this sort of idea of return to work is looming over them all the time. They're always very aware that there's a degree of pressure there, so they have a tendency then to try and raise their activity levels to almost prove that they can go back to work, and there's a tendency then to crash. So I think that what we've tried to encourage people to do is not to put that pressure on. We want them to improve and we want them to get back to work, but then we don't want them to push so hard that then they have this massive drop in their ability that then tends to be a drop in mood as well.
Okay, and that will relate to this next question, is how important do you think it is for patients to see the objective measures as part of their rehabilitation?
I think it is. I think it's such a useful tool. I think we needed to recognise why there was that strange pattern in what was happening when we were doing some of the objective assessments. So I think we needed to recognise that, but I think that then any sign of improvement is great. I mean, we had, with that particular lady, there was some of the rehab stuff she was doing. She hadn't done it for a few weeks for one reason or another, and then when she went back onto the Primus, some of them had increased by in excess of 200%, whereas in her mind she still felt pretty rubbish and was still experiencing these fluctuations. And to be on a week where she wasn't feeling so great but still be significantly better when she first saw us, I think is highly motivating. But also it can be a little bit dangerous because it's a snapshot moment, and what we need to explain to people is that it's great that you've done that and it's great that you've achieved that, but that doesn't mean we're ready to go, because actually it's only a snapshot. It's over a session that's no more than an hour, and we're not going to be in a situation where we can go back to work for 4 hours at a time. I think we're just getting a fit note now. I don't know if you'll be able to see it. Sorry, I should have put it up on the screen. Can you see? So this section here says difficulty, and this says recommendations and goals. So I think it's very therapy driven, and you can say that with your employer's agreement you may benefit from these options: phased return to work, altered hours, amended duties, and a workplace assessment. And at the top here, you're not fit for work, or you may be fit for work, taking account of the advice below. So it's much more lengthy. It comes with a great big explanation that you can give to employers as to why they're getting something that looks different to what they expect. We've probably written around about 250 since Christmas, and the only employers we had issues with was our own, with the trust. They didn't like them. They said, oh, they rejected them, and then we've got there, but I had to escalate that quite high in order for them to see that actually they were getting better information than they would normally get. So yeah.
And so in relation to that then, so that looks quite a comprehensive form, and Rosie, who's one of our other Primus users, she thanks you for the presentation. And then do you manage to carry out the questionnaires, producing fit notes, liaison with employer in that hour treatment session, or is there additional time needed for that?
I would say we do an awful lot more than we've ever done before by email. If the patient's in agreement with that, you know, we bounce things backwards and forwards quite a bit, I would say, but we do quite a lot in the time. I think we're very lucky, we've got brilliant assistants, so they can facilitate a lot of the treatment, and they will, you know, we can come and so if we needed to do a fit note because that was a degree of urgency to that, then we would come in here into the office and do that, and they can carry on doing their treatment. So, you know, but I am lucky because we've got a great team here. So that said, you know, because we can send them electronically, then often they'll go, you know, we'll do a lot of the assessment side of things, and then we'll do stuff, and then we'll send it to them. I think it's keeping on top of when the fit note expires, how much time have I got here. You can backdate them. So, I mean, obviously you wouldn't want to do that significantly, but it wouldn't be a massive issue if you didn't send the fit note for a couple of days, because you can just backdate them, that's fine. But yeah, there's lots of bits to it, but we do that with everybody. It's not just these COVID patients, so it's something that we're always doing.
Okay, great. And now's a good time for me to say we're also on our panel. I've got Jeff Johnson, who is joining us from the US. Hello, Jeff. Jeff is the clinical specialist at BTE. So I'll ask this question to you first, Sarah, but Jeff may want to support with some of his experience. So have you been utilising eccentric strengthening options due to the fatigue elements with the patients?
Not particularly.
Jeff, can you join us in on that one? Because that may be something that you can talk about.
Sure. So the eccentric aspect of Primus would be used in conjunction with the concentric. So if you're focusing on an isolated movement like elbow flexion, you would do the concentric flexion piece and then the eccentric lowering it. So eventually you'll see a session that will produce more work output because you're essentially getting 2 for 1. You're getting 2 to 2.5 repetitions per 1 repetition when doing the Con-Ec mode. So the Con-Ec mode can certainly be very helpful to those patients who have some limited metabolic capacity.
Okay, great, thank you for that. And just again, while you're involved on this, Jeff, what would you normally expect to see? Like Sarah was demonstrating the fluctuation for these particular patients, COVID patients. What would you normally expect to see from a patient who'd been using Primus or any other strengthening exercise regime?
Well, Sarah had a great example of a patient who saw a 200% improvement with a function. And it's not unlikely to see patients their first visit, when you do that objective assessment, to see that their output is very low, their force output is very low. And when you reevaluate and, say a week or 2 weeks or even a month later, you're going to be able to see that comparison, that percent difference, that percent change, and somewhat justifying your the services that you're offering. But it's not unlikely to see patients see 50 to 100%. I've seen some pretty high changes in just a short period of time. And it just shows that a person may not really perceive that they're getting better, but objectively they are, and you can show them that they are, and that can be reassuring and helpful to patients. So that's a great example that Sarah had.
Great, thanks, Jeff. So this question, so Sarah, how long have you been using the Primus, and which particular patient cases were you seeing using the Primus pre-COVID?
Oh gosh, I don't know, 4 years? 4 years maybe?
Yeah.
Something like that. And we use it a lot, an awful lot. And the thing here, we see such a broad range of conditions. So as I say, we're primarily an MSK service, but we have been known to treat neuro patients. We tend to treat patients that can't go anywhere else, if that makes sense. So where there's not a specific, other therapy service, then we'll tend to treat them. Anybody really that needs to go back to work with some sort of physical dysfunction who doesn't have access to another therapy service is really our target audience. So we run a spinal rehab group. We use it quite a lot with them. The work that Andy mentioned that we've been doing income generation work, we use it a huge amount. For those patients, we use it for helping. It's Rolls-Royce, the company. I think that's fine to say. At the moment, it's very quiet because they've lost an awful lot of staff at the moment. But we use it a lot to help with decisions on redeployment. We've been really, really keen to try and look at hotspot areas where we know there's huge musculoskeletal problems, and trying to use it as a preventative measure as well. So trying to understand how we might assess somebody who potentially wants to go and work in a particular area of the business. It's something that I believe they started many years ago when Rolls-Royce had their own Primus, and then it all changed and they lost a lot of that work. But we have shoulder group of patients, so we do an awful lot of post-op shoulders rehab. We also, our physios in the team use it for some lower limb assessment for ligament reconstructions. We are tight on funds in this department, so to have something as valuable and as comprehensive as the Primus has allowed us to, we will literally thrash it because we'll use it as much as we possibly can, really, to get the most out of it. So yeah, I mean, it's endless, really, I would say. And staff, we do staff service quite a lot, and that's a pre-existing thing, really. And we're trying to work with our occupational health service have just employed an OT. So we've always been involved with them, but they've never actually employed their own occupational therapist. So that's just hasn't started yet, but that's going to happen. And I think it would be, again, lovely to look at the hotspot areas for musculoskeletal conditions within the hospital as well, and I think that it would have a really big part to play in that. We also in the trust have another 2, 3 on the other side. Yeah. So, you know, potentially if we can set something up, it is something that we have the ability to do with the other machines that we have in the trust.
Yeah, absolutely. And you mentioned working with that particular manufacturer. How do they engage with the actual data that you provide them? Do they like seeing that?
They do, but we interpret it. I think we've worked with them a long time now, so we interpret it because we know the sort of information that they want. We were actually guilty of giving them 2 comprehensive reports to begin with. They actually asked us to make it a little less comprehensive, so we try to interpret it, and a lot of the time we're doing it having already seen their place of work. So we try to make sure that they understand why we've done that particular assessment and how we think it relates to the job that the patient does and what we've seen, not just what they tell us. So a lot of the time with our NHS patients, we're going on the information that they give us. We can't possibly do work assessments on everybody, but often with Rolls-Royce, we've already seen it. We know the job. You know, there's particular places. There's one particular place I've been to 15 times to the same place because they have such recurrent problems, shoulder and upper back problems. That makes it very easy for me to really, you know, set or set people in a very specific way. So yeah, I think they like us to interpret it, I would say.
And is that the same for internally within the trust as well then? Do you give data to them?
Yeah, and we do. And we're doing more and more of that, like I say, and hopefully that's going to develop further. So I think that it will be an opportunity for us to have things to hand that, you know, we're not always starting with a new raft of evaluations and treatments, that it's something that we can call on when we know that somebody's coming from a particular area of the trust. But it is something that I believe I'm going to be supervising the person that's coming into the occupational health post, and I would really welcome the opportunity to get occupational health here, using it as much as we've been able to do that with Rolls-Royce, because it seems ridiculous that we feel like we provide a better service externally than we do internally.
Yeah, that makes sense. A question about the standard evaluation that you were hoping to use for these COVID patients. Yeah. What actually was that?
Well, we didn't go that far, to be honest with you. It's all, as I'm sure everybody's experienced, it's just been a bit mental, really. It's been crazy. So I think I often have these ideas and then don't quite follow through with it. I'd be interested to know if anyone else had ideas, or certainly if Jeff knows of anybody that's doing anything, because I think that one of the reasons we had quite a lot of, I don't know how many referrals we've had for COVID patients now, but we've had quite a few, but I still think there's loads out there that we haven't had, and I think more will come to light. And I think that not because we're advertised, so to speak, in the trust even as a musculoskeletal therapy staff service. Essentially, this is obviously, it's not a musculoskeletal condition, so I wonder how many people just haven't been referred. So I think there's still more development to come. So if anyone else is doing it, or anybody's got any ideas, then I'd love to know.
I think that's something which Jeff and I will definitely speak about, because we're working on some other projects in different areas for burns patients specifically, putting together a protocol. So there's definitely some research opportunities that are out there. There's quite a few Primus users that are on here now. So we'll send something out on that one as well. So we'll push that one forward. So a question here. So do you take any patients from outside of the Derby area?
Yeah, loads. Yeah, well, we're now, our trust is now University Hospital of Derby and Burton. So there's 5 hospitals just within our trust now that go across 2 counties. So we definitely take patients into Staffordshire. We also take patients from Nottinghamshire. I mean, I think the fact that we are doing a lot of virtual consultation at the moment, but our rehab still works best face to face. So I think there's got to be a limit to how far people will want to travel for regular rehabilitation, which I believe is where we're most successful. So, but yeah, so it's mainly our neighbouring counties, but definitely we do, because there aren't a lot of services like hours out there. So I think people, certainly now that we've merged with Burton, has expanded that quite a bit.
So why would you say that there aren't many services doing what you're doing then?
I don't know. I don't know really. I think, I mean, I like I say, I've been here a long time, and we've always done some form of work hardening, was always the thing. And it's just developed. I think we've been very lucky to survive, because I think rehab of this kind went off the boil a little bit, and there was quite specific rehab for hands, or, you know, there wasn't a lot of OT in anything rehab related, musculoskeletal wise anyway, for anything other than upper limb. It seemed to disappear. So we were always known as the heavy workshop, and as far as I'm aware, most large hospitals had heavy workshops 20 odd years ago, and they slowly disappeared. So I think that there's a lot of places that touch on it, but there's not a lot of places that are exclusively for that purpose, maybe, in this country.
Yeah, that's the experience that I've seen. That there were a lot of, when I started off working with BTE, there was a lot of heavy workshops, but a lot of them replaced those heavy workshops by getting a Primus so that they could be objective with it. So yeah, I would agree with your response on that. And something it's kind of a strange thing, but like what are the positives would you say that you're going to take forward from this, like the remote management? Has that been successful?
Absolutely, yeah. But there's things that we will always do differently, as far as I'm concerned. You know, I think actually it's encouraged us to encourage our patients to self-manage more effectively, to become less reliant. What I think a really interesting group of patients for us is that the occupational therapists in my team lead on total knee replacement rehab, which is unusual. It's mostly physio-led, nationally speaking, but a lot of them now are of working age. A lot of them have the surgery done because they want to be more functionally independent. So we started taking a lead on that quite some time ago, and actually I don't think they've been any worse off by not coming in, which is a big statement, I know, but we've done a lot of stuff with them, and I think there will be people, and there certainly will be people who need our support and need to come in if they're going back to work. But I certainly think, I don't know whether it's because they don't expect it. So we've been doing electives now for, I want to say June maybe, they restarted elective surgeries, and they've done really well, but I think they knew they had to just get on with it themselves. I wonder whether not having that pressure of constantly having their range of movement monitored, and you know, they literally do seem to have flourished, and I think we'll rethink that an awful lot, and I think that I think the main thing is about trying to encourage them to self-manage and to use some of the ways that we've done it. I think we're going on to electronic records that we've never done before. We've been trying to do it for ages and we've never managed it, and it's given us a real push to do that, because we've got therapists doing virtual consultations at home, because we're quite small. There's not much room here, as Andy will know, but so we're having to make as much best use of the space as we can as well. So we've got laptops. We've never had so much IT in our building ever, which is a miracle. And and I think we've taken the pressure off the almost conveyor belt. We just treated so many people. We never stopped. We'd come in at 8 o'clock in the morning and we'd go all day long, not stopping, and seeing so many people all the time. And I think we've sort of considering quality now over quantity, and what people can do to help themselves, because ultimately they do need to be independent and need to make these decisions for themselves. So trying to push them in that direction, I think, has been really positive, if that makes sense.
Right. Yeah, no, well, it's definitely good to take something out of this. So that definitely is a positive. So we're going to finish off there. So just say, Sarah, thank you very much for your time, and thank you, Jeff, for joining us as well. So it's not on this list. Could you just put the list up, please, Sarah? Just go back one.
Oh, wrong way.
There we go. Yeah, so we've got some upcoming webinars. Before I go on to those ones, I've not told Sarah this, but we are hopefully going to be doing one on her, on how she managed to get the income generation and the business case for the Primus. I've been pushing her on that for probably about 4 years, actually, haven't I? So no, we'll look forward to doing that one definitely at some point. So in terms of other things that we've got coming up, so we've got one in half an hour, which is Jeff and I looking at neck pain. Also got one next week on soft tissue management for the performing artist, which is with a clinician based in Baltimore, which will be very, very interesting. And then one with another one of the people who asked a question earlier on, with Rosie Deer, talking about the management and treatment of a breast cancer patient. And another case study that we've got, and that's with Rosie Deer, who will be talking about how they use the Primus within that, as well as LymphoTouch, the targeted negative pressure system we've got. So we've got things coming up all the time, so please check our website, check our social media. Mary will send out the information after this with a questionnaire, so if you could fill that in, that would really help us to give us feedback on how we're doing with these things and any other topics that you want to see. So other than that, have a great Friday, and thank you again, Sarah. Thank you, Jeff, and we will speak to you soon.
Thank you.